Thank you so much for the lovely introduction, Pierre. I'm Christina Scali, and I've met many of you in the office. Thanks so much for having me here to talk to you today about skin cancer awareness and prevention. And it's really appropriate because May is actually Skin Cancer Awareness Month. And thanks for taking the time out of this beautiful day to come here today and learn something. So this is an outline of what we're going to talk about today. We're going to talk about the function of skin, ultraviolet light, skin cancer, sun protection, and then sunscreens. So this is a schematic showing us the skin. It's the largest organ of our body, and it has so many important functions. You need it to be intact for life. So the top layer is the epidermis, the middle layer is the dermis, and the bottom layer is the subcutaneous or the fat. And within the skin, there's lots. There's hair follicles, there's sweat glands, blood vessels, nerve endings. So this is just showing there's lots of functions of the skin. One of the most important is in protection. The skin forms a barrier between an inside of an organism and the outside. So in doing that, it protects physical trauma, thermal, chemical. It also prevents the entry of organisms, like infectious organisms, and also helps protect against UV radiation, which is what we're going to talk about later. It's involved in fluid balance. It regulates body temperature. Sweating allows us to cool the body down. If we're cold, our hairs stand on end and we shiver, providing warmth. It's very important, along with UV light, to make vitamin D. That's done in the skin. There are immune cells in the skin, and then it's involved in communication with the nerve endings. So this is just showing the electromagnetic spectrum, and this is the energy that is emitted from the sun. One portion of it, is ultraviolet light, and that's right here next to visible light. So ultraviolet light is divided into 3 different types based on the wavelength. The longest is UVA, we see here. UVB is the intermediate wavelength, and UVC is the shortest wavelength. This just shows the skin. The epidermis is the top layer and the dermis. So UVA has less energy, and it penetrates deep into the skin. And UVA is quite responsible for the aging from the sun, but it's also involved in skin cancer generation. UVB is shorter wavelength, but it has really high energy, and it penetrates the top layers of the skin. UVB is the main cause of sunburn and skin cancer. And then UVC doesn't reach the earth, it gets filtered by the atmosphere. So UV light is not all bad. As we said already, you need UV light along with the skin to make vitamin D, which has lots of important functions. It also seems to be protective against some autoimmune diseases. When you move closer to the equator, there seems to be a decrease in some autoimmune disease. It's very important and helps inflammatory skin diseases like psoriasis or eczema. And then it improves well-being and seems to have a lower risk of depression. So we know that UV radiation is harmful. We just talked about sunburn being mainly caused by UVB, skin cancer from UVA and UVB. Both UVA and UV also suppress the immune system, and that therefore make it easier for cancers to grow, and then aging. So this little schematic just shows how UV radiation causes cancer. So the UV light hits the skin, and its UVB damages DNA. UVA does it in a different way through free radicals. But once you accumulate enough mutations in the DNA of cells, then a skin cancer forms. And because they're both suppressing our immune system, it makes it easier for skin cancers to grow. So there are many risk factors for skin cancer. You know, the lighter skin types, lighter eyes, lighter hair, advanced age, just basically related to the more sun exposure, history of sunburns, tanning bed use, history or outdoor occupation. History of skin cancer does make you much more likely to have other skin cancers. Immune suppression, say you have a transplant and you're on immune suppressive drugs, there's a much higher chance of skin cancer. And then there's some rare inherited syndromes. So first we're going to start talking about actinic keratoses. These are precancers. They're usually from damage to DNA by UVB. They're found usually in sun-exposed areas, so the balding scalp, face, tops of the hands, forearms, or tops of the feet. When you feel the skin, they're often rough, and they're often pretty ill-defined, red and scaly. So these are precursors to skin cancer, and that in particular the squamous cell carcinoma. The rate of them developing into a squamous cell carcinoma is quite low. It's 0.001% per lesion per year. But when people have sun damage, they usually have many of these actinic keratoses, so that increases the risk. Plus, it's hard to know which one is going to turn into a skin cancer. So some worrisome findings are if an actinic keratosis becomes painful or starts growing rapidly or becomes really thick or ulcerates and bleeds, it's possible it's transformed into a skin cancer. So how do you treat actinic keratoses? So we just said they can lead to skin cancer, so very important that we do treat them. There's two general ways. One is hitting the lesions themselves. We call it lesion-directed treatment. The most common is the cryotherapy or the liquid nitrogen. So liquid nitrogen is about minus 192 or 96 degrees, and it freezes the top layer of the skin and causes cell death. The other less common ways are you can curette or scrape the actinic keratoses out, or you can cut them out. The second way we remove actinic keratoses is what we call field therapies. So these are treatments that are used to get rid of an entire damage in one certain field, like treating, say, the whole balding scalp or a full face. And the idea of these treatments are you're going to be attacking not only the actinic keratoses you can see, but you're getting the ones that haven't yet emerged, so they're subclinical. So these are really useful treatments, and I know a lot of people don't like doing them, but we always really encourage them because they're really going to reduce your chance of skin cancer, and they'll also reduce how many actinic keratoses you'll develop over the next year. So the most common ways we do that are through creams. Effudex is by far the most common. We probably use this one 99% of the time. There's imiquimod, and then there's photodynamic therapy is one we do in our office. Instead of you applying a topical chemotherapy for 3 or 6 weeks, we do it in one day in the office, and we use a photosensitizer. We activate it through light. And sorry, just going back to this, you can see that this lady has treated her cheeks and nose, and these field therapies, they bring about a lot of inflammation. So you get redness, erosions, crusting, and it can be painful and itchy. So now we're going to talk about the skin cancer. Basal cell carcinoma is the most common type. It makes up almost 80% of all skin cancers. It affects about 50 to 60,000 Canadians per year. In general, these are lower risk skin cancers. They tend to grow slowly, they grow locally, and they almost never go to other parts of the body. There are several different subtypes, and this is the nodular basal cell. So it usually presents as a pearly bump. Sometimes you can see blood vessels. It can be crusted or bleeding, and the face is a really common site. This is another common site, or subtype, I should say. It's the superficial subtype. This is when you have red, flat areas. On this figure, you can see that this patient has multiple superficial basal cells, and these tend to occur in younger patients. So that's a close-up of a superficial basal cell. The less common type is the morpheoform or sclerosing. These are scar-like areas, usually on the central face. These often extend a bit further than you can see, and they can be a bit more aggressive. So how do we treat the basal cell? We can use a variety of ways to treat them, and really it depends on the subtype, the size of it, and also the patient preference. Surgery is done by far for most of them, but there's also other things we can do. For superficial basal cells, the cryotherapy can often work. We often do curettage and cautery. We scrape away at the basal cell and then we cauterize it. You can use those topical chemotherapies I mentioned, or the photodynamic therapy. And then sometimes if patients aren't surgical candidates, we do radiation. For more advanced basal cells, there's drug therapies. So this is the squamous cell carcinoma. This is the second most common type of skin cancer. This affects 20,000 Canadians per year. Unlike the basal cell, these can be really aggressive. They often will grow quickly over weeks to months. They can be painful, and they can often be really thick or keratotic. So the squamous cell has a higher metastatic rate, 0.5 to 10%. And this depends on the location of the squamous cell. So the ear and the lip have a higher risk of metastases. So how are these treated? By far, surgery is done for most of these. Often, radiation needs to happen after, especially if there's nerve involvement. And then for more advanced squamous cells, we now have some immune therapies that can be done. But in general, for surgery, you want these taken out as quickly as possible. So what is melanoma? So melanoma is a cancer of the melanocytes, and those are the pigment cells that produce our skin color. So the melanocytes, you can see in this schematic, they sit in the epidermis, the top layer of the skin, but they sit in the bottom layer, and they produce melanin, which gives pigmentation, and they transfer it to the skin cells. So when they grow normally, they form moles or freckles, but when they become cancerous, they form what we call melanoma. We have about 5,000 diagnoses per year and 900 deaths in Canada from melanoma. So the risk factors for melanoma are similar to what we talked about for the non-melanoma skin cancers: older age, fair skin, history of sunburns, and in particular, blistering sunburns. Having ever used tanning beds is now known to significantly increase your risk of melanoma. Having a previous melanoma puts you at higher risk of having another, or having a non-melanoma skin cancer also puts you at risk. Having lots of moles, and then having 5 or more atypical moles also puts you at risk. If you have a strong family history of melanoma, that's an increased risk. That's when you have 2 or more first-degree relatives with melanoma. And then if you're immune suppressed. So it's important to know that melanoma can occur anywhere in the body, even sites of the body that are not exposed to the sun. It can be in the mouth, in the genital area. It can occur in the eye, and even in the brain. And another important thing is 25% of melanomas actually come from moles, but the remaining 75% actually just grow up on normal skin. In men, the most common site for melanoma is your back, and in women, it's the back of the legs. So there's a few different subtypes of melanoma. This is the most common. It's the superficial spreading melanoma. So in general, usually you see it's asymmetrical, the borders are regular, you have more than 2 colors within, and the lesions tend to be larger. This is another photo of a superficial spreading melanoma. You can see it's asymmetrical, it's irregular, there's more than 1 color, and it's by far much larger than this patient's regular moles. The second most common type is the nodular melanoma. This makes up 15% of all melanomas. These tend to be symmetric, smooth bumps on sun-exposed areas. These are only associated with moles 3% of the time. So most of the time, they just grow up on skin with no pre-existing mole. So 30% of the time, though, there's no color in these nodular melanomas. These are called amelanotic melanoma. And because they don't fit the typical picture of what we think is a melanoma, these are often diagnosed late with worse consequences. The third most common is the lentigo-malina melanoma. This makes up about 10% of cases. These are generally in older patients, and they're in areas of the body chronically sun-exposed, so they're almost always on the face. They're very slowly growing, and over time you see an enlarging irregular patch that eventually develops bumpy areas within. And then finally, the acral lentiginous melanoma is the melanoma that affects the palms, the soles, and the nail bed. So in Caucasian populations, this makes up about 2 to 3% of all melanomas, so it's very infrequent. But in darker skinned, it's actually the predominant melanoma. Sometimes it can be up to 60%. So in this case, we don't feel sun exposure plays a role. But again, you can see an irregular patch. It's not, the borders are regular, it's asymmetrical with different colors, and it's large. So we all have heard of the ABCD criteria of melanoma. This schematic compares benign lesions to malignant on the right. So first, you're looking at A, asymmetry, whether the two sides match. If you were to cut them in half, are they the same? B, the border irregularity, so the border's uneven. C, color variegation, so there's often 2 or more colors in melanoma. D, diameter, they're often bigger than 6 millimeters. And then E, evolution, or any change in one aspect of the mole. So for nodular melanomas, remember I told you they're symmetric usually, bumps, they're even. This doesn't fit. This is more for the superficial spreading or the acral lentiginous. So what I find the most useful sign, especially when we're looking at skin, is the ugly duckling sign. So when you're looking at a patient's skin in total, you're looking for that mole that looks different than their pattern of moles, because every person has different patterns. So you're looking for the one that stands out. And I think this could be really useful when we're doing self-skin checks. So how is melanoma treated? For the most part, we do surgical treatment, occasionally radiation. The more advanced melanomas, we have immune therapy and targeted therapy. And I just wanted to add that we've come so far in the last few decades with advanced melanoma treatments. Patients are doing extremely well on these targeted and immune therapies. So that was the first part. Now we're going to talk about sun protection. So basically, sun protection doesn't just involve sunscreens. What else can we do? So we can do clothing, hats, sunglasses. We can avoid the peak sun, and we can avoid tanning beds. So some clothing has been designated a UPF factor rating. This is similar to SPF. It's special fabric that protects the sun, and they've measured that level of protection. So UPF stands for ultraviolet protective factor. I'll just give you an example. A UPF of 50, which is a good protection level for clothing, means only 1 out of 50 UV rays pass through, and 49 out of 50 are blocked. So you're getting 98% protection. So I think aiming for like at least a 30 plus is good for the UPF ratings. And just to compare it, a regular white cotton t-shirt is only a UPF of about 5. So you're really not getting much protection from just an average t-shirt. So these ratings are found not only on clothing, but also hats. So we alluded to this earlier, but we now know with lots of evidence that tanning beds are very dangerous. You know, they're artificial devices used to tan skin, but they don't mimic the sun's UV rays or energy levels. There's a much higher incident, the much higher proportion is UVA, and it's much stronger intensity, so much more damage happens. We know now that there's a greatly increased risk of melanoma. Some studies have shown just using a tanning bed once increased the risk of melanoma of 1.8%. And another one has shown, even having ever used a tanning bed, you have a 20% increased risk. We also see that risk for the other skin cancers, but it does appear to be higher for the melanoma. So WHO have put it into a group 1 carcinogenic for humans category. And in some countries, they're banned altogether. And in others, like Canada, they're banned for minors, depending on the province, under 18 or 19. So what are sunscreens? Sunscreens are barriers applied to the skin, and they protect against ultraviolet radiation. And as we said, it's important because it's going to prevent sunburn, it's going to reduce skin cancer, reduce pigmentation, and aging. So they contain filters that block UV light, and there's 2 different categories. One are the chemical sunscreens, and they work by absorbing the UV radiation and transferring it into heat. The physical sunscreens, like zinc oxide or titanium dioxide, they're thought to, the majority way of doing that is by reflecting or scattering the UV light. There is some evidence, though, there's a little bit of absorption, but predominantly it's through reflection and scattering. So what is the SPF of sunscreen? So that is the sun protection factor. And I just wanted to go through with you how it's determined. So for example, they're looking at how many minutes does it take to burn with sunscreen divided by how many minutes does it take to burn without sunscreen. So if it took 150 minutes with sunscreen to burn and 10 minutes without sunscreen to burn, that gives you an SPF of 15. Now, when they determine these SPF values, they use a large amount of sunscreen. So it's 2 milligrams per centimeter square. And they've done studies looking at how do people actually put this amount on. And most of the studies have shown people only put on about 25 to 50% of what they're supposed to. So what that means is you're going to get a reduction in the SPF. If you're someone that puts tons of sunscreen on, a very thick layer, you'll get the actual SPF listed on the bottle. But if you're like almost everyone else, you're going to have to reduce that SPF by 25 to 50%. So this gets us to the question, what SPF should we be using? So if we look at this graph down here, down at the bottom is the SPF, so from about 5 to 65. And then here you're looking at the percent protection that ranges from 80 to 100. So you can see, let's take an SPF of 15. Well, first of all, the curve sharply increases at the lower SPF values. But then when you get from around 30 to about 60, it's leveling off. It's not increasing as quickly. So I get asked every day in the office that there's no difference between 30 and 60, so why do I need to use 60? You have to think about it. If most people are only putting on half the amount they're supposed to. So if we start at a 30, and you're putting on 50% of the amount that was done in the studies, so you're using half the amount, you're actually getting a 15, so you're somewhere in here. And then if you start at a 60 and you're putting half the amount, you're going to be down here. You're getting a much higher level of protection. So the higher the better, but at least a 30, and if you're going to put tons on, a 30 is fine. So broad spectrum means it protects also against UVA, and this is important. We mentioned UVA is the main driver of photoaging, but also pigmentation and skin cancer. So the Canadian Dermatology Association has given some guidelines on sunscreen use in Canada. They recommend wearing it daily in Canada from April to September. If you're outside in the winter, so in particular skiing, you're going to get a reflection from the snow, then you should be wearing it in the winter as well, if you have a lot of time outside. So in general, we tend not to put enough on. They recommend an adult wearing 2 to 3 tablespoons of sunscreen for the entire body, or 1 teaspoon to cover face, neck. So we're just going to go through some common sunscreen myths. You know, these are questions we get asked quite frequently in the office. So myth number 1, if you tan but do not burn, you don't need to use sunscreen. So we talked about when the skin is exposed to UV light, the melanocytes produce melanin, and they give that to the skin cells to protect their DNA from damage from the light. So you get a tanning response. So any tanning is actually a sign of sun damage. If you have a tan, it's actually not providing you with much protection. You're actually only getting about an SPF of 3 out of it. So you can still burn, and you can still develop skin cancer. So the second myth, you do not need sunscreen, or you do not burn through a window or in a car or under an umbrella. So although the umbrellas and the glass, they do reduce the transmission, they don't completely eliminate it. For example, the umbrellas at the beach, it really depends on what that fabric is. If you have a good umbrella, you're going to buy one with a UPF rating of at least 50. But despite that, you're still going to get reflection from the sand. So you should still be wearing your sunscreen. So myth number 3, sunscreens cause cancer, in particular oxybenzone or the retinol palmitate. So we feel that there's no evidence these chemicals cause cancer in humans. A lot of the studies that led to these reports were done in the lab. There was one where they fed rats massive amounts of oxybenzone, and then they did develop changes. But this is not levels, it's not relevant clinically because these aren't levels that we get in our body. We get minimal absorption. when we put it on our skin. So the Canadian Cancer Society has issued a statement that they believe that oxybenzone, retinol palmitate do not pose a cancer risk. And actually, you could say the opposite. By not wearing sunscreen, you are at a risk of cancer. So myth number 4, that sunscreen damages the coral reefs. So I know lots of countries, Hawaii, now Mexico, they're making you use reef-specific, reef-safe sunscreen. There are not a lot of studies actually showing that the sunscreens are the cause of the bleaching. So they're done in the laboratory at 1,000 times the levels that are found in the water, and those have shown some bleaching. And scientists agree there is sunscreen filters in the water, but what they don't agree on is whether that level, it's much too low to be causing any damage to the coral reefs. There is a feeling, though, that the global warming and the increased water temperatures, which affect algae growth, are leading to the coral bleaching, and also some chemicals from agricultural runoff. So obviously more studies need to be done, and we do see sunscreens in the water, and you have to follow the country's guidelines for sunscreen use. But to date, there is no real evidence it's actually causing it. Sunscreens prevent vitamin D synthesis. So the studies have shown that most people get enough vitamin D production when the UV index is high enough. In Canada, so in the summer, you will get enough vitamin D production just from your incidental exposure, your day-to-day activities. So you don't need to deliberately expose part of your body with no sunscreen, say 15 minutes of your face before putting anything on, in order to get that vitamin D, because you'll be getting enough just from day-to-day activities, even wearing it. Now, when the UV index is not high, so most of our year, apart from summer, it's recommended we do either a supplement or increase our dietary intake. So how do we apply sunscreen? So we want to apply it liberally to all exposed areas. And remember, we want to try and put a lot on, or we're not going to get that SPF listed on the bottle. Sunscreens work right away when you put them on. You only need to wait 20 to 30 minutes if you're going to go in water. But you don't need to wait 20, 30 minutes if you're not going in water. They work right away. You should reapply it every 2 hours, or if you're staying out in the sun. And you definitely want to reapply it after swimming or heavy sweating, or if you've been towel drying. And then insect repellents can reduce the sunscreen's SPF. So I just wanted to show this emblem, the Canadian Dermatology Association. If you go to their website, they have listed all the sunscreens that they approve. They've looked through all of them, and the ones they approve have to fit this criteria listed on the bottom. So they need to be broad spectrum, so they cover both UVB and UVA. They need to be at least an SPF 30. They need to be hypoallergenic, non-irritating, minimally perfumed, and water resistant. And because no sunscreens are totally waterproof, so you should have a water resistant label on it. And that is it.